Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And we are honored today to have as our guest Dr. Robert Kruse. Dr. Kruse is the state medical director and also the head of the Department of Public Health for the state of Iowa. Welcome, Dr. Kruse.
Thank you for having me here.
Well, it's great to have you, and we're going to talk about public health and its role in cancer control. But before we do that, let's get to know you as a person. So where are you from originally?
That's a great question. So I actually grew up outside of Chicago in a suburban town, Des Plaines, home of the first McDonald's, but I don't know if we tout that as much.
Right. I have been to Des Plaines, yes.
Yes.
And they pronounce the S. It's
yes.
Des Plaines.
It's very confusing for us here in Des Moines, yes, yes.
And so how big of a high school did you go to? How many in your graduating class?
There was just a little bit over 500, actually. It was a pretty large school class, yeah, about 2,000.
So what was your personal claim to fame at your high school in Des Plaines?
I was one of the top 10 most active seniors. So I was just involved in a variety of clubs and activities, whether I was a choir boy. I did a lot of plays and skits, for school, ski club, photo club. I mean, had a DJ for a radio, WMTH radio. I don't know if it's still going there in the high school, but we shared that with some of our district high schools. And so was just very active, involved in curriculars at that time, and played a lot of sports too, tennis, wrestling, believe it or not, in freshman year. Wasn't as tall there.
Okay. What weight did you wrestle as a freshman in high school?
I was much shorter. Let's put it there. I was actually 130.
Okay.
Yeah.
My favorite, my neighbor buddy of mine was 98 pounds.
Okay.
And then from high school in Des Plaines, where did you go?
So my parents were actually originally from Iowa. They moved back there, and so I was looking at intuition and looked at University of Iowa. Both my parents went to Iowa State, so I probably had to spite them a little bit there. But went to University of Iowa and studied biomedical engineering.
And did you know as you started college that you wanted to become a doctor?
Actually, really wasn't until kind of the last, really one of the last semesters I was really interested. I mean, I had thought about it. Typically, biomedical engineers in my class were going into either grad school for their PhD. Some were going directly into industry, and then about a third of the class was also then going into medical school. So there's a lot of the same kind of classes and curriculum that the medical students take. And at that time, I was very involved with a club foot brace, designing a club foot brace at the University of Iowa, and we were working on a patent for that at the time. And so it wasn't really until I was volunteering at the hospital and the university that I got more involved in that clinical care and really wanted to kind of get into medicine, I should say.
And then where'd you go to medical school?
So interestingly enough, I went down to St. George's University in Grenada in the West Indies. So I was in the Caribbean for a little bit of time, did my book work down there, and then did all my clinical training up in New Jersey in the Northeast.
Okay. And was that, I know that you were at Rutgers for part of your training. And so then obviously medical school,
yep.
You then have to decide what you want to be when you become a doctor.
Yes. I thought coming from the engineering side, I love surgery, working with my hands. Biomedical engineering, we were doing a lot of implant models for research and stuff. And just at that time, thought I wanted to do surgery. My last rotation of my third year medical school was family medicine. I really enjoyed the kind of different diversity of kind of cases and individuals, children all the way to adults and end-of-life care. And we were unopposed residency, and so that's a residency program that doesn't have other residents in the community hospital that we were training at. We were sponsored by the university at the time, but we had a lot of exposure to all the service lines, in that hospital. So we did clearance for our inpatient psychiatric units. If there was not an attending for obstetrical care, was assigned to the residency program, and we were first assistant surgeries at that time too in the middle of the night. So it was just really great training, and ended up staying on as chief resident, and then staying on for faculty with the same program there at Rutgers.
And I know at some point you got the Master's of Public Health, but did you practice as a family medicine doc or after your residency, or did you go right on into public health?
Good question. I actually did my master's in public health in St. George's before medical school, so a little bit of a break in between. Wasn't directly into medical school. I did my MPH in environmental and occupational health, actually, and so was at a practicum site down in Sarasota County, Florida at the time, in their environmental health department, and great experience. I mean, it was everything from inspecting tattoo facilities to tanning beds to kind of actually measuring different muzzles for water quality inside of the estuaries inside of Sarasota. So it was a really great experience.
Okay. And then once you finished your residency, then I know that part of your career you were at Mercy One as director of occupational medicine. Tell us a bit about what is occupational medicine and what was your primary role as an occupational medicine specialist?
Great question. So occupational medicine, people typically get exposed to them either due to work injuries or, sometimes due to regulatory physicals. So it's really, occupational medicine is really a background of the clinical work that relates to disease and injuries that may occur in work. And a lot of it is focused on prevention. Most of occ health physicians have a background in public health, typically, and their focus is typically prevention work inside of workplaces. But it can be anything from regulatory drug testing, FAA physicals for pilots, DOT physicals, so a lot of regulatory physicals, making sure people are, fit for duty, make sure they can do the function of the job well, and make sure they're not going to, have hazards to themselves or injure themselves in their job role.
Right, right. So as I think about it, I was a Navy doctor for a while, and I had to, approve. I was in undersea medicine of all of the divers once a year, and I mean, basically, that would have been a sort of a function of occupational medicine, making sure that the person was fit for the particular skills and physical rigors of a particular occupation.
Yes, I mean, that is kind of it in a nutshell. I think, it happened to be in the middle of COVID or transition to COVID, and so kind of the work transitioned a little bit. We focused a little bit more on disease mitigation inside of workplaces. We would do a lot of work inside of different kind of businesses to make sure that they were safe to continue working, or creating hybrid models or testing models or immunization, at the time for individuals in work settings.
Okay. And now, as I said at the outset, you are the state medical director and also the head of public health. How would you describe your current role? The roles that you have?
Sure. So it's unique, right? As a state medical director, typically you're a physician, have that clinical background, and then you have kind of public health programs that you oversee and run. And so it's a unique role where you're giving a lot of clinical direction around health policy, around prevention activities, and around just making sure people are aware of how to be healthy in general in our communities. And so I think the distinction from, kind of healthcare delivery is typically as a provider, you're typically seeing an individual patient one at a time, or seeing maybe a family member at the most. Public health is really about population-based health and thinking about strategies for improving health from a larger kind of public basis.
And did you become state medical director during COVID or after the COVID?
So I started in October 7, 2022, to be very specific. So right on kind of the tail end there, transitioning there. I was just very interested in public health when I was at Rutgers teaching as assistant professor there, teaching the residency teaching program there. I was kind of bringing the core work of public health and prevention and teaching that kind of curriculum and didactics for our students inside of Rutgers.
So even though we talk about health and I'm part of a healthcare system, it still seems to me that most of healthcare is about treating illnesses the way that we do it in the United States. And obviously public health as a big thing is as an entity is really about trying to go upstream and really deal with health and prevention of disease. How do you describe what public health is?
That's a good question. So I think, very for a routine answer for that, I would say it's seeing more than one person at a time. That's distinct from healthcare delivery. But I would say when we talk about these prevention activities, we talk about kind of a treatment-based healthcare that is occurring right now, and moving upstream to those prevention activities, and that's can be anything from surveillance, so making sure that people are aware of kind of the diseases or the mortality or morbidity that people are experiencing, so then we can understand how do we use our dollars or our policies to help inform us how we can improve those aspects of prevention. And so that's just one way. There's also assurances, so making sure people have assurance to access to healthcare delivery and healthcare services. And there's a large component of traditional public health was based on kind of acute infectious diseases, and there's a large component of that. I mean, we have an Ebola outbreak going on in Democratic Republic of Congo right now, and we're very involved with those particulars. Wide spectrum of activities, and I think it's when there's disasters, natural disasters, or disasters that happen, we also get involved for those public health responses as well.
When you think about public health in the prevention, what are the different buckets of prevention that fall under your leadership?
So we see, prevention could be from, overdose prevention, like from opioids, for preventing people from overdosing on those and thinking about strategies to help prevent that. Could be around just disease and communicable disease infection prevention. Some of these are also outlined, primary, secondary, tertiary prevention, right? Preventing, kind of an outcome from even occurring in the first place. Once someone gets, a disease or illness, how do we prevent complications from occurring potentially? So there's a lot of prevention activities in that space as well. I think the other part is we do a lot of screening, right? So we're focused on for cancer, for instance, how are we going to detect cancer, whether it's lung or prostate? How do we make sure that guidelines are current, and how do we make sure that providers who are doing those screenings are most up to date with those providers so that they can screen the population involved?
Well, let's talk about cancer now. So the role of public health in terms of cancer control. And when I say cancer control, I'm thinking about, preventing cancers that are preventable, early detection, access to care, treatment, and then everything beyond. What would you say is the role of the state medical director and the Department of Public Health in terms of cancer control?
So I think there's multiple facets there, and I think you hit on some of those. There's a prevention piece, making sure that people are aware of ways to prevent that, whether it's wearing sunscreen or whether it's being aware of radon and making sure people have access to mitigation services. I think it's important that we talk through, what are the screenings that are available to people as well. So I think it is through that entire continuum. As a medical director, part of our role is to ensure that our healthcare providers are up to date with their guidelines, for screening activities. Part of that is making sure the general population, the public population, is up to date about kind of risks and how they can mitigate those, whether that's risks at work, maybe there's exposures they have, occupational exposures that may lead to cancer, or thinking about other activities about how they prevent that, for instance, from kind of a workplace setting. I think about that often. I think the other part is, we gather a lot of data. We work with contractors like the University of Iowa, for instance, to help gather data to inform us where are we seeing clusters of cancer occurring, or where are we seeing cancer, showing up in different disease or populations, so we can kind of again address those and try to understand the why behind that.
So Dr. Mary Charlton, who is the head of the Iowa Cancer Registry and professor of epidemiology at the University of Iowa, has been our guest. What's the relationship between public health at the state level and, for example, the Cancer Registry, which we all rely on as the keeper of the statistics, the collection of all of the data, obviously because cancer is a reportable disease, we've got very good numbers on incidence and mortality. And does that fall under the state Department of Public Health?
So we work with the University of Iowa as a contractor for that work, specifically with the Cancer Registry. They're really the listed entity for the state of Iowa for this registry. They help to acquire it, obviously the reportable conditions piece of getting that information. But part of it is how it fits in this broader cancer control plan. And so that we work with the Cancer Consortium specifically to think about just all the aspects of that continuum of care, whether it's prevention, whether it's early detection, whether it's that treatment access, or whether it's survivorship. And so we work very closely. We know that as a health department, we can't do that alone. We need to work with our communities, our stakeholders from hospitals, community sectors of work, thinking through, again, all those aspects of care. Because it doesn't just happen in a public health department. It happens every day when people are out at their workplaces or at the schools. How do we get together around kind of addressing this together?
And then the structure across the state, because I think every county, maybe some double up, but there's county public health directors. And do they report up to you? Is that part of your job and organization, is to have policies that start at the state and move out to the different counties?
Yeah, so we have 99 counties, and we have 99 health departments, local health departments there with 99 kind of administrators. Some are hospital based, some are county based, and I think there's a term. If you've seen one local health department, you've seen one local health department, and I think you probably say the same with state health departments too, 50 states. But the idea is that we have information that we work with, but they're really the boots on the ground. They know their communities, they know their jurisdictions well, they know their hospitals, they know their resources in that community, and so they really are the ones working with the populations in their jurisdiction to help access resources, care, navigation of services. A lot of that's happening just much more at the local level, and so oftentimes we'll create communication kits that at the state, address some cancer screening or recommendations around tick-borne illnesses or other variety of things, and we push those out to our local public health partners to use and distribute around their communities as well. So it is a multifaceted system, but at the end of the day, they do have local control. They're able to have really a decentralized system where local powers exist for those authorities exist at the county
right.
level.
So you help them by providing them tools, but they actually report to the county
Correct.
leaders, and so each county could decide to focus resources on different aspects of public health.
Yeah, if you have a lake in your community, you may have lake kind of illnesses or lake things to address, versus something that doesn't have a county that doesn't have that body of water or something. And so they're going to have unique kind of public health needs. And I think that's state by state too, right? A lot of states, they have their own cancer risk factors, but for us, radon is very kind of distinct. And so obviously we have a unique way at the state of we have to think about how we want to address that. And so I think the same thing goes for those local counties. They have their own unique needs and to address those as well.
Yeah. Well, let's talk about radon a bit, because as you pointed out, that is a problem that is very much prominent in the upper Midwest, Iowa and surrounding states, and does contribute to our high cancer incidence. What is your role, and the role at the state level for radon? Number one, assessing the concentration and then mitigating. And then I certainly invite you to talk about some of the new legislation that passed that is going to be able to help with radon control.
Sure. Yeah, absolutely. So I think as medical director at Iowa HHS, our focus on radon, is to, number one, make people aware of it. I think it's similar to a lot of it's like carbon monoxide. It's distinct from that, but people just don't see it. They don't smell it. They don't have really indication, but it's in this background. And cumulatively over time, as we get exposed to that, obviously it can have health effects, most commonly in the lungs that we're aware of. And I think, our role is really, number one, to make people aware of this environmental potential risk factor for cancer. Number two is also then, once it's identified, how do we mitigate that? How do we prevent that? And so we also license actual radon mitigators who actually do the data collection to ensure we have accurate results, but also they work on the mitigation aspects of that. And so as a health department, we're really focused on a role of radiation health protection. It's in our Radiation Health Bureau, just given it's radon, but our focus is how do we prevent people from being kind of exposed to that, thinking through that.
And then when legislation is being considered, do you, as the medical director, do you testify at committees and do you advocate? Do you you get involved at all in the details of legislation?
Yeah, I think it depends on the type of legislation. Typically we're there to provide an education and background so people understand, really what they're voting on and understand the specifics, especially as it relates to some of the health systems that we work through, not health systems, but local public health systems, and kind of how that would roll out, if they were to, recommend a certain legislation piece. I think our role is to help, provide them awareness about what that would do, both from a financial standpoint, but also like outcomes, and to consider that when we're doing that. I think there's also parts, though, that are agency bills, from Iowa HHS that we have kind of pre-filed at times, and typically we'll work with our director of the department on, testifying, or work with our legislative liaisons to work on that piece. But sometimes a lot of that is working just in tangent with our health director, or our director, I should say, of Health and Human Services.
Okay. And we made some advances in radon control this year. I know there was at least one bill that was passed a few years ago. One of my patients, who was a teacher, a non-smoker, developed lung cancer. That's when she found out her radon level was high in her home, and became just an incredible advocate. And just a few years ago, the Gail Orcutt radon school safety bill was signed into law. She had worked on that for a few years. Unfortunately, she died before it was signed, but it did finally pass. Like many pieces of legislation, sometimes it takes a few years before it gets across the finish line. Can you update us on the new laws that were passed this year?
Yeah, I think our focus really on a lot of these laws is to, number one, think about when we're going to be testing, radon for, different home ownership, for instance, that's occurring. We're also focused on, legislation. Last year we had a bill that provided about, I think it was $20,000 in radon test kits at that time, and I'll just reflect on the need there. They went through those test kits in about, I would say, about a month and a half or so, maybe even less than that. And so clearly there's a need. People want to test. I think the next step is, though, how do we mitigate that? And even if there's not legislation involved, we also think about other aspects of either funding or resources that we can have to mitigate that. And I think about our Healthy Hometowns, our rural health transformation program that helps to provide access maybe for radon mitigation, for testing, for individuals as well. We're working with Marion County Public Health Department right now on some screening statewide for that, and kind of rolling that out soon too.
Okay. Yeah, we'll talk about the rural in a bit. Let's talk about the screening. We were chatting about that a little bit before we started the interview. Right now, there are 5 cancers for which there are validated screening tests: prostate cancer, breast cancer, colon cancer, cervix cancer, and lung cancer. And I know there is a program at the state specifically around breast and cervical cancer. Is there a Department of Cancer Screening, or how does the Health and Human Services approach promoting cancer screening?
Sure. We have a bureau called Bureau of Chronic Congenital Inherited Conditions, and we have a lot of chronic illnesses in there with diabetes, but we do have a strong focus on cancer. And so we have one of our staff members focuses on the cancer control work, as we're kind of working with Healthy Hometowns. That's kind of a new funding piece that's come to us through kind of the federal legislation around that. And so we're thinking about, again, anytime we get new legislation, we don't necessarily need to kind of reinvent things. It's just how do we augment that? How do we make sure that kind of resources we have are being used effectively? We have programs like the Care for Yourself program for breast cancer. And so there are people who meet certain eligibility requirements based on either underinsured or lack of insurance, or just in a gap, maybe they don't qualify for Medicaid, for instance, and they may then be able to access this screening services. And so that's just one avenue, particularly for breast cancer. And I don't know the numbers with me, but I think we've annually we count how many people that get screened, and working with medical providers and oncologists and primary care docs to get those screenings to occur.
Right. I think Care for Yourself, if I'm correct, is breast and cervix. cervix
Correct.
cancer.
Yep.
Yep. And so obviously, I work for a health system, and health system's one of the jobs is to screen. I mean, it's something we keep track of. It's something we monitor. And now, as every health system is getting more sophisticated electronic medical records, the tracking of that is becoming easier and should be able to not only track it, but with the electronic medical records should be able to prompt the communication to encourage everyone to get screened. And so I'm making a point that obviously it's many people in healthcare's job to try to increase the screening rates. It's not something that you're responsible for every person in the state of Iowa, but you have the opportunity to enhance that. And do you feel that your role is to work, to what extent is it communicating to the public at large versus, communicating to the health professionals in terms of, let's say, cancer screening?
Yeah, I think it depends on what the specifics are. When we're talking about updated guidance, for certain screening, whether it's for HPV cancer or cervical cancer, I think it's making sure that our providers are up to date. I mean, things move fast. Depending on which guidelines you're following, it's just trying to keep pace with some of those. And so there are aspects where we want to make sure we're informing providers of those updates or novel techniques that are more efficient. We're seeing dramatic outcomes or improved outcomes from that. But I think the most significant part is, informing the public. And so I think there is depending on who our audience is, we think about all of our audiences across the lifeline and across different occupations and perspectives. I think we also think about our local public health providers. What is their role to inform communities? We have medical providers, local providers, our own public population, and so we need to think about that continuum of where we inform people. If I would go back to, you mentioned just kind of the screening and the ability, to think through that. I think one of our roles also is how do we create tools that are available to make sure that we have interoperability between different healthcare systems or community systems and make sure our electronic health records are up to date. If you saw, one of your patients saw someone from a cardiologist appointment and are returning back to you, sometimes you're waiting for the faxes to come through, and believe it or not, we're still sometimes using our HIPAA compliant fax machines, but using an HIE, if we're not all in the same EHR, that's a mechanism that allows us to have that information flow. And I think as we're getting more and more interoperability to occur in the healthcare systems, I think the next steps is, how do we think about that from a community-based care, whether it's a health department or a WIC clinic or these other aspects of integrating kind of that care continuum and understanding just, if my patient saw the cardiologist, I want to make sure I have that echocardiogram results in front of me so I can make the right decision at the right time with the right data in front of me.
Yeah, and you mentioned community resources as well. So, as someone who's a professional in public health, I mean, we could spend an hour talking about social determinants of health, and that, health is so much more than what happens in medical clinics and hospitals, and that the things that determine health come from, income and education and the built environment, and, where are their grocery stores and where are their food deserts. How, as the state medical director, do you think about those social determinants of health that are just the way we live in the community, not related specifically to healthcare systems?
Yeah, that's a great question. I think most of the outcomes we're seeing are related to these social drivers, social determinants, non-medical drivers of health. I've heard, depending on which jurisdiction, what term you're using,
Right.
but I think it's easy for you or me to prescribe a metformin or a medication drug. But the challenge for the patient may sometimes be just getting transportation to pick up that medication, for instance. And so I think, as medical providers, we're so focused on obviously the care of the patient in front of us, but, comprehensively, as a community, we need to start thinking about those other aspects of care, whether those transportation needs, the built environment, the housing. If you don't have a roof over your head, are you more likely to get that medication, pick up and take it if you're kind of in that bind. So we're trying to think, and equip us with our human services. I think that's the big part of us coming together, integration,
Right,
become
it's
public
health
health
and human services.
How do we make sure that we're working together to inform each other on that and working across our division, not just within the public health domain, but our Medicaid domain, our early childhood, Iowa domain, or our family well-being domain, thinking about just all those aspects of where those resources are available for patients. And so we're still in our infancy, I would say, as an agency, and we have a lot of growth to happen around where we can really integrate much more of our work together in the communities. And we've hit a lot of those strides going forward, but I think there's a lot of opportunities for us to continue to work on that.
Right, just kind of gestalt. You think of health as doctors and human services as social workers, and it's like mind, body, spirit. I mean, you can't really separate human services and the social determinants of health from the delivery of health care.
Absolutely, absolutely. We know that much more of the outcomes are driven by those social drivers.
So I attended a conference just a few weeks ago, and it was on cancer in rural America, and it was focusing on some of the special concerns. So, for example, if you just look at the statistics, individuals who live in rural communities compared to urban communities have a much higher mortality rate from cancer. And they also have greater financial toxicity related to cancer treatment, and outcomes just are not as good. I know that there is a push right now, some federal funds about rural health, and that there's lots of activity happening at the state. Maybe talk a little bit about how you see the difference between rural health care and urban health care, and then talk a bit about the opportunities that Iowa has through the Rural Health Initiative.
Sure. So I think rural populations are unique. I mean, the services and access to those services can be a challenge for them, and it's not necessarily a cost piece for them. It might be just access to specialist services, access to therapeutics or treatment, and sometimes you have to travel 2 or 3 hours, 2 hours just to get maybe a therapeutic oncology infusion or something like that, and so this rural health transformation program came out of some federal legislation that occurred last July, and we are calling our project the Healthy Hometowns. And basically, it's how do we improve the outcomes, increase access to individuals who live in rural communities, improve health outcomes for those individuals that live in those communities, and ensure that those living there can have a well-being similar to the same as what we have access to here in urban areas as well. And so it's really based on a series of different things, such as bringing make sure that we have equipment and the right types of therapeutics like infusion centers or rad oncology, bringing those more into rural communities and bring out that service line for hospitals to have access for individuals in that community. Also thinking about telehealth work. How do we augment that where that's needed, where we may need to have visits that don't necessarily have to be in person, where that can happen. How do we make sure people can stay in their home and access that same delivery of care? Part of that is thinking through equipment such as dermatoscopes, so primary care physicians to screen for melanoma more effectively or more efficiently, to provide that information to a dermatologist or a dermatopathologist, to review specific cancer cells that they're seeing, for instance. Also thinking again about access to those screening services, right? Lung cancer screening, is there access to a CT scanner within, a low-dose CT scanner within your vicinity? So again, thinking about that. And then thinking about, again, a series of kind of coordination hub and spoke models of care. So there's been a big build towards an infrastructure towards rural health. Number one, we have coordination access to services for infusion, for oncology services. How do we make sure, though, that there's coordination between the primary care doctor and this hub type of care model? And so we're really kind of rolling that out to help build up that infrastructure to help ensure there's access for those individuals in those communities.
And that's happening pretty quickly. I mean, the goal from the federal legislation was to get it out there and get the money distributed. And it's a bit of to try to mitigate against some decreased funding that's going to happen in the future related to some Medicare adjustments and other changes in the budget that's going to have a negative impact. So this was my understanding, to get some funds out to help the states, because they're going to face some obstacles in the future once the all of the details of the big beautiful bill go into effect.
Yeah, I think I think there's a big transformation piece of rural health care, specifically just to ensure those access there. And I think, there's a lot of, again, opportunities for us to think about how we augment that. I think for us, Iowa got $209 million this first year for improving that access. And we were first in the nation to get those dollars out the door. And I think a lot of states are actually looking at us about how we did that very efficiently. There's also, if you don't spend those dollars, our partners at the federal level will take those back, and there's it's a 5-year grant, so the continuing years there'll be kind of a redistribution of those funds if you don't spend those. And so I think strategically Iowa took a very significant position through our leadership to move those dollars forward and think about that strategy very early on. We started meeting with our hospital and healthcare partners even back in August to think about the strategy, where I think some of our states are kind of waiting until the award came out and then thinking through that. So,
Right.
We kind of really hit the ground running for that.
Yeah, I actually was in a meeting with the governor yesterday, and apparently there's some states that haven't even kind of launched their RFP projects yet. And the state of Iowa, as you mentioned, was first in getting the money out the door and into the hands of rural communities where it can be of benefit.
Yeah, absolutely. I think some states have legislation where if it's a certain dollar amount of an award, it has to be reviewed by their legislators, for instance. And so there's a lot. I mean, like I said, we've seen one state health department, you've seen one state health department, and so we just had a great opportunity here.
So we've seen that challenges are significant, and some hospitals are actually closing, and many hospitals are reducing their departments. For example, OB departments, the number of hospitals that now deliver babies compared to 10 years ago is significantly less. What are other challenges that you see in rural communities, and maybe describe, and you did to a certain extent through the hometown, what you're trying to, through the grants, to allow more individuals to get their care closer to home.
Sure.
And part of that is developing partnerships, hubs and spokes, et cetera.
Yeah, I think that's one component. I think you touched upon kind of a workforce challenge we have, and I like to call it the 2034 problem, because I think we're going to hit our probably peak healthcare demand is typically age 77. So most individuals use healthcare at age 77. And our
when
general
we
population
baby
hit that.
boomers.
Yes, I wasn't going to call you guys out.
Well, I will call it out. Yes, we just have overwhelmed every aspect of what happens. From the time of having to build so many new schools as the baby boomers got into school, to now Social Security and Medicare, as we are overwhelming those systems.
Yeah. So, part of it is how do we build that workforce, for addressing that? I mean, we're already in a shortage now. You mentioned the OBGYN shortage here. But that's, it's several service lines that we're missing, providers or specialists, involved. And so per capita, we look at that closely. I think our Rural Health Transformation Program, Healthy Hometowns, has a provider recruitment strategy to help kind of maintain people in those rural communities, for individuals that will stay in those rural communities for about 5 years of a commitment. CMS has said we can actually, use some funding to help reimburse those costs or cover their costs for for maintaining them and retaining them inside those rural communities. But I think it also, it's as a medical director, we also need to think about, that's just one aspect. How do we think about graduate medical education? So how do we make sure that people people are more likely to stay here in Iowa if they train here in Iowa statistically. And so how do we augment and build up the programs that are needed for the future workforce, whether it's OBGYNs or pulmonologists or cardiologists? We want to make sure we're expanding access for that graduate medical education programs. And so from someone who came from a residence teaching program, I know how significant that kind of need is, I think, from family and primary care physicians, but it really is across all specialties. So we need to be thinking about, the future workforce, how our graduate medical education will help to prepare for that. But as you know, it takes 4 years of med school, 4 years of undergrad, 3 to 4 years, 5 years, depending on your specialty of care. And so it's a long road ahead, and we need to be thinking about that probably. We're probably 20 years in arrears to, really kind of address that fully. There's been different aspects we've been doing here, but we really want to kind of help build out some of that graduate medical education programs.
Do you get together with other state medical directors around the country? Is that do you have a once a year, all the state medical directors get?
Yes, we will. So I belong to a group called the Association of State and Territorial Health Officials, and I sit on the board actually there, representing Region 7, so Iowa, Nebraska, Kansas, and Missouri. And so we just had a board meeting about a week or so ago, and it's these challenges, these public health challenges, whether it's rural access or whether it's maternity care or preventing maternal death, preventing tobacco use or opioid overdoses, these are not necessarily unique to Iowa, but how we address those, here in Iowa and our jurisdictions, may be very different just based on kind of geographic needs or what that might look like specifically.
So are you aware of some novel programs in other states that you've heard about, thought, oh gosh, that seems like a good idea, maybe we could bring that back to Iowa? Are there some novel programs that are happening elsewhere in the country that piqued your interest?
Yeah, I think, healthcare affordability seems to be a very hot topic across the nation here. And so just listen to my colleagues. That's something that I don't have specific engagement here around that, but we've been talking collectively about just how do we make sure that people can access that healthcare still, regardless of where they are at in their life. People need to have access to that. And so thinking about just either value-based care models or models that can help drive kind of care delivery as well. And again, it's kind of unique to public health. That doesn't it shouldn't necessarily be owned by us. We need to work with our insurance teams, our healthcare and hospital care delivery services, because we need to make sure whatever is proposed really is going to work. Some people do that through a certificate of need process or other aspects of how to manage healthcare delivery, so you ensure access for individuals and it's sustainable over time.
Okay. We're going to open up to questions. We've got about 15 minutes left. So we have a live studio audience. They get first dibs at you with questions. But if you are watching us live streaming right now, you can also ask a question. Just put your question in the comment section of the software you're using. Yes, Ron.
Yeah, well, I'm hoping you have a great staff to address all of these issues that you've been talking about.
We have a fantastic staff, and it's like I said, it's beyond my division of public health. It's really a very mission-driven staff, that people who want to work at HHS, they're really focused on the people and who they're serving. So I certainly I do not wear just one singular hat. It's really a shared aspect of how we do our work.
And I know certainly the water quality in Iowa has been an issue for a long time, and the spotlight's kind of starting to focus on that a little bit. And just kind of wondering if there's any thoughts of collaborating with the Department of Agriculture to maybe talk about farming practices that might improve water quality.
Great question. So I think we've seen a lot of news about that, and we're doing some work with our with the University of Iowa on those cancer drivers to try to understand from a population health perspective why we're seeing kind of the rates of cancer that we're having. I think cancer we know is very complex. It's not necessarily one single kind of unique exposure or unique kind of implication that causes you to have cancer. I think we need to look at that throughout, whether that's behavioral, challenges, whether it's genetic reasons, or whether there's environmental contaminants. I think it's certainly not just public health. We need to work with our Department of Natural Resources, our Department of Agriculture, across this. It's really a collective conversation to have about what could be happening around specifically to cancer and what specifically can be done around that. And I'm hopeful that working with the University of Iowa, we can understand a little bit more specifics of kind of what's driving kind of the cancer that we're seeing here in the populations, and really to kind of drive home a little bit about the why from that and try to work on some of those activities. So I think there's still a lot yet to be understood and learned specifically around just why Iowa has the rates that it does. And I think that we need to be having an open mind about how we address that collectively, not just in public health sector, but across our state government as well.
When I had one public health official and was giving me sort of the history of public health and is in England, and it seems like part of the origin story of public health had to do with infectious disease and contaminated water and a pump in the middle of London, and I forget which exact disease.
John Snow and cholera, yeah.
There we go.
That's
It was
the
yeah.
father of epidemiology.
Right there. So where does water quality fit into state government in terms of responsibility?
So certainly, from a regulatory standpoint, water quality is under the Department of Natural Resources. And specifically, we work with them, collectively on health concerns and health impacts as our sister agency. But really, from a regulatory standpoint, the DNR is typically the ones that oversee that. At the same time, we have programs that we work with the DNR about the health impacts about private wells, and ensuring whether it's PFAS or other contaminants that people are testing those. It's different. It's different than kind of the Des Moines Water Works here or Central Iowa Water Works. I forget their name now, but they are they're very focused on they have their own systems for screening. But when you're out in a rural space or a rural area, you're kind of reliant on that water source, a private water well. It's really kind of up to you as a owner to make sure you're testing for that. So I think we think about programs about how we make that affordable, working with the DNR on that and ensuring that they can go through the state hygienic lab, to get those tests occurred, for that.
Okay. Next. Yes.
I actually have two questions, if I may.
Yes.
You've touched on so many of these already, but if you had to choose one looming challenge for you in your position, what would that be? And then second, how do the responsibilities of your position interface with the whole issue of the cost of pharmaceutical drugs, prescription drugs?
Great question. So I think the biggest probably challenge as a health director and talking to my colleagues across the nation who are state medical directors or state officials, health officials, is really trust. I think public health has lost that kind of value of trust that individuals have had as a society to the point where it's disrupted communications and kind of this authority that state health departments or health departments have had. And so part of that is how there's so many communication channels between Twitter and social media and all these different communications that are coming through. Sometimes that creates a challenge about who is a trusted resource. And we know now that individuals, whether it's family members or the communities they live in, they're more likely to trust people who they're around. And so we've lost a lot of kind of trust from health officials. I think that's something that collectively all of us are trying to work on. I think some of us, historically, we've been doing public health kind of in the background. When you brush your teeth or when you're drinking water, that's really public health has been there to make sure you have, fluoride in your toothpaste to prevent cavities or preventing communicable diseases. Unfortunately, we kind of had our first date with COVID, and the public put a limelight on us and has kind of diminished a little bit of the trust that's happened with health officials overall. I kind of link it up to a fire. Everyone knows a firefighter is going to hopefully, show up to a fire, obviously. But public health, it's hard to recognize what public health is and what we're doing in the background. A lot of times, whether it's Ebola, travelers that we're monitoring, or whether it's hantavirus or other aspects of kind of disease monitoring that we're doing, a lot of that's happening all behind the scenes and is quiet until it becomes recognized as a bigger thing or creates a bigger outbreak or more individuals are involved. And so I think trust is still an avenue that we're trying to address. I think if I were to try to focus on a specific kind of disease or something like that, I think we're also at an uphill battle with just being very intentional about health. I think we put it as kind of the back of our minds when we're making decisions, whether it's behavioral decisions about what we're going to eat, what we're going to drink, what we're going to do or smoke, or all those things, go to school. And I think there's a lot of opportunity for us to think about, how do we make the healthiest choice the easiest choice for individuals to make, and how do we really put health as a primary aspect of our lives. And so, again, not specific to public health. We need to really work with our schools, our employers, our community leaders around what that could look like.
Good thing is that a lot of the messaging is over all the different chronic diseases. So when we talk about a healthy diet to help prevent cancer, the good news is it's the same diet that helps prevent heart disease and diabetes and strokes, and so makes the messaging a little easier. You don't have to choose, well, this diet's to prevent cancer, this diet's to prevent diabetes, et cetera. But yes, many of us, a lot more of us would get an A on the written test than on the practicum.
Yes, very well.
Yeah. Now, the second part of the question
Yes.
was, do you have any role, responsibility, or way of addressing the cost of pharmaceutical drugs?
Yeah, specifically for us in the Division of Public Health, I mean, and I guess for my role as state medical director, there's opportunities for us to work, with our cross sector across our agencies, sister agencies, whether it's the Department of Insurance, our Medicaid division, for instance, where people are getting access to care. There's opportunities for us to link up with that as well. I think a lot of it, though, is federally driven, and so we need to think about kind of state policies that may help to bring down and lower those costs. But a lot of those costs are set at a federal level, at this time. I just think there's some areas, though, where we can work together and think how we can deliver those costs a little bit lower at the state level as well with our kind of insurance area in state government.
What percentage of Iowans get their health care insurance through the state programs, Medicaid?
I don't have the specifics right now, and there's been quite a bit of change after the unwinding a little bit there, but it's certainly more than a quarter,
It is,
much
yeah.
more.
Yeah.
I think that there's opportunities for us to think about just with that population, to be very specific and intentional, but then we lose out on people who may not have that insurance altogether, and how do we address those as well? So again, when we think about public health, we try to think about the general larger population when we address those, but if there's kind of specific things that the agency has levers to pull for policy reasons, we can certainly affect those as well first.
Okay. Other questions? Yes, Ron.
Yeah, just maybe getting back to the water quality, and maybe this is more of a comment. It seems there's been a big problem with nitrates, and we do know where those are coming from. And it seems like across the government that there's been little mitigation introduced to try and circumvent that.
Yeah, I think, like I said, I think there's certainly a lot of aspects to be looking at about, how we can improve water quality for a lot of reasons, whether that's algae blooms for the environment or other aspects of that. I think there's a lot of opportunities for us to be thinking about just how we can improve, the water in general. Again, I certainly don't want to talk out of turn for our partners in IDOLS or our other sister agencies on how to address those. And I know there's been, quite a bit of funding to help address some of those programs through nutrient reduction, strategies as well. But I think that, we want to make sure that we leave no stone unturned when we're addressing kind of cancer drivers, and certainly need to make sure we're comprehensive on how we approach that. And so I think all of us together collectively, whether it's us at the state or our individual partners and stakeholders, our farmers, our other occupations throughout rural America as well, we need to be thinking about how we can address that effectively.
Yes, Boone.
You mentioned fluoride. So with our reverse osmosis system, it removes the fluoride. Is there concern with the little kiddos not getting enough fluoride?
So if somebody puts in reverse osmosis, is that going to take the fluoride out of the public water?
Yeah, that sometimes is a concern. So that reverse osmosis process you're describing takes out a lot of ions that are inside of there. Some are added intentionally, like fluoride, to help prevent dental caries. I think that there's also a lot of fortification of fluoride in a lot of different spaces, whether that's our toothpaste or other aspects of that. But there is, especially in rural spaces where maybe they, again, don't have a lot of that fortification in what they're, either putting on their teeth or other aspects of that, there could be a potential diminishment of that. And so I think it is something that we're watching closely on policy around those concentrations inside of our larger water systems. But we know that there's evidence to help support that it prevents dental caries, and certainly I think that where there's sometimes challenges with access to either dentists or dental services, that fluoride kind of water, community-based fluoridation, really helps to prevent those as well. And so I think we need to be thoughtful about kind of RO, kind of mitigating or reducing that fluoride. If obviously, you want to see your dentist and get a checkup to see if it's really having a diminishment, by your healthcare provider there. But there's oftentimes, if we see an offset of kind of a lower concentration in the waters due to RO, certainly I know dentists or physicians that may prescribe, fluoride tablets or treatment as well.
And do we have a question from any of our viewers?
Yeah, a question from YouTube. A viewer wants to know if there's any program or any thinking or possibility of mitigating the cost of an RO system for people, particularly out around the state. The majority of Americans can't afford a $500 emergency, and an RO system would fall into that. So how do they afford it? Where do they get one?
Yeah, I think that's something that we want to be thoughtful about as well. Right now, I think we don't have a very specific program, scoped out there. I think, collectively, again, when we talk about public health, we want to try to address that on a larger scale, whether that's kind of making improve access for RO treatment, or trying to do that more from a municipal water supply, system. I think we need to think about all those avenues, but right now we don't necessarily have a specific program that provides RO treatment.
And we have run out of time. Our guest today has been Dr. Robert Kruse, the State Medical Director and also the head physician at the Department of Health and Human Services. Thank you for being with us. We're going to have to bring you back again.
Yeah, absolutely. Thank you for having me here, and I enjoy speaking here as well.
Thank you. If anyone watching this program tonight knows someone that would benefit by watching it, good news, it's going to be available on demand and can be seen tomorrow, beginning at the Above and Beyond Cancer YouTube channel and also the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.
Thank you.
Thank you.
Yeah, absolutely.